Good evening, everyone. Welcome to the series of webinars by NANS. I'm going to give a couple of minutes for everyone to kind of join in here. So today's topic is really near and dear to my heart. It's neuromodulation for cancer pain. This webinar today was a product of educational committee endeavors, and with the support of the board of NANS, we were able to present these series of webinars for you. We have gathered today some real thought leaders in the field of neuromodulation and cancer pain management. So I'm really excited to be a part of this webinar, and we have a really nice, engaging conversation planned for you for the next hour. Next slide. We're going to briefly go over the introductions of everyone. I can start with myself. I'm Hemant Kalia. I'm one of the interventional pain and cancer rehabilitation doctors practicing in upstate New York and Rochester, New York. For the last 8.5 years, I was with a big health system, and I recently decided to go private.
Hello, I'm Amit Gulati. I'm a physician, and I've been a physician for 16 years in Memorial Sloan Kettering Cancer Center. We've been hopefully taking care of our patients pretty well. Had some pretty good experiences with neuromodulation along with my colleagues here, and hopefully we can shine some light on how we can do some of these concepts to your patients and your practices. I'll hand it off to Dr. Sindh.
Hello, good evening. My name is Jill Sint. I'm one of the cancer pain physicians at University of Utah Huntsman Cancer Institute. Our focus in particular is on intrathecal drug delivery for cancer pain, and we have a large volume program in that regard. Tonight we'll be talking about some different interventions that you can bring to your patients, some of the advantages, disadvantages of each, as well as what particular therapy might be best for each particular patient. I will hand it off. Let's see, Dr. Patil.
I'm Parag Patil. I'm a functional neurosurgeon at the University of Michigan. And so I have a practice that spans neuromodulation, including deep brain stimulation, spinal cord stimulation, vagal nerve stimulation, and also ablative neurosurgical procedures, particularly for cancer pain.
Hi there, I'm Scott Pritzlaff. I am an associate professor here at the University of California, Davis in Sacramento. I'm also the program director here. My interest, a lot of my interest recently is focused on peripheral neuromodulation, specifically focused around use of ultrasound and kind of novel ways of implementing peripheral nerve stimulation in chronic pain states, including cancer patients.
Great. Next slide, please. So the way we have designed this webinar today, we want to bring home the concepts of problem-based learning. We know that if we put some really challenging concepts in the context of a clinical scenario, we're able to bring that concept home really, really nicely. So what we have done in this specific webinar is we have some really interesting cases. We'll go over those clinical presentations, and our panelists are going to go over some of the pearls and associated neuromodulation aspects for that specific cancer presentation. We're going to delve into building a robust referral pattern and differences between a true interdisciplinary and a multidisciplinary model of care for cancer pain management, especially when it relates to neuromodulation. We'll also delve into briefly about the pearls of practice development at different aspects, be it academic center, health system level, or even a private practice level. And then we'll take the questions at the end. And I'm really excited that this is going to be a really good webinar. So, Dr. Gulati.
Excellent. So thank you very much, Dr. Kalia. Next slide, please. Oh, you got it. We're going to really focus on a couple of cases that Dr. Praslov has been pioneering some peripheral nerve stimulation. So really some ideas on how we can apply these kind of techniques and technologies for our cancer patients. I'll present the cases, I'll hand it off to the group, including Dr. Pritzloff, and give some really good pearls on how we can introduce these devices to our patient population. So next slide, please. So, one of the challenges we have in oncologic disease as opposed to chronic pain states is that many times the tumor, whether it's metastatic, cancerous, or benign tumors, such as in this case, I'll describe briefly, the same innervation of the periosteum is also involved in significant motor innervation. So this is a patient who is a 58-year-old female, had a history of breast cancer, and she actually survived her breast cancer. And actually had stayed on hormone replacement therapy for a while, but unusually developed fibrous dysplasias, which were not metastatic in breast cancer, but actually just odd disease state of the long bones. And her most serious pain center was actually the right humerus. So she had pain essentially up or down her main arm, a little bit in the forearm, but clearly. One of the issues we had is we are not able to deinnervate this. So common strategies are, in oncologic disease, maybe to deinnervate the location of the pain, but obviously if we are to destroy the brachial plexus or something here, would lead to severe comorbidities. So the patient originally responded to stellate ganglion blocks, which we commonly do for some of these situations, unfortunately temporary pain relief. And then we decided to, target the brachial plexus. And what I'd like to do is pass it off to Dr. Pritzloff and some of his thoughts and techniques on these techniques.
Great, thanks, Dr. Galati. So, really a couple of things with some of these patients, and taking a step back actually and asking the question, why peripheral nerve stimulation in cancer patients? What is the benefit in some of these cases? And when I talk to patients, I bring up a few ideas and a few thoughts. One is, obviously, these patients are undergoing a lot of treatment. They're often immunocompromised. And as much as in a lot of cases, I love doing spinal cord stimulation for pain, a lot of these patients can be anticoagulated. And so peripheral stimulation can be something in your toolbox because if you look at ASRA guidelines, this is considered to be a low to intermediate risk procedure. And so these procedures, in my mind, can be done on patients that are considered to be higher risk and patients, frankly, in many cases, anticoagulated and still see benefit with decreasing amounts of risk compared to maybe something in the neuraxial space. With that said, this is not a panacea. And so certainly in this case, Dr. Galati, you were targeting the brachial plexus, and with PNS, you're able to target these peripheral nerves and often do this with a minimally invasive technique with ultrasound and place either a permanent system or even a temporary percutaneous system that may stay in perhaps for 60 days to give some element of relief. The question always is, with a temporary system and you place a lead next to a mixed motor sensory nerve and you're trying to treat someone's pain, are they going to get some element of durability? And that is the case sometimes, but not always. And so that's a consideration. In these patients that you're targeting more proximal nerve roots or the more proximal brachial plexus, one always has to take into account as well wearability. All the peripheral nerve stimulator systems that are available currently involve some sort of wearable device to power the system. And so that's a consideration. That's something you have to discuss with the patient, that they're going to have a wearable somewhere, in this case, either on the upper chest or shoulder area. And so there is a commitment to therapy, but nonetheless, you can, if successful, you may be able to cover this area of pain at the brachial plexus level. Perhaps we talk about the next case.
That's great. Next slide, please. I think Dr. Pritzloff brings up a great point about durability when it comes to temporary type systems, but in oncologic disease states, that's actually somewhat helpful sometimes. So this second case, what we're really doing here is we have a patient that has a myxofibrosarcoma, so a tumor of the actually evading the hips, some lower part of the ischium, all the way into the femur and the soft tissue surrounding it. It was actually radiated and resected previously. This was years before I even saw the patient. But she needed to have her device fix removed and replaced, and how the whole system had to replace for a new system and the right hip. So for someone, and this particular patient, I told my patient today, she did not tolerate opioids well. So we can get her through the actual, perioperative phase of this case can be completed with a neuroaxial system such as an epidural. But really looking at what can we do post-operatively for patients that have severe situations where they can't tolerate opioids, where that's the mainstay of at least perioperative oncologic pain care. So in this particular case, we took a little bit of a novel idea, which was we don't have, a peripheral target per se. Yes, easy to do, but we have selective nerve roots that are targetable. So for postoperative care, I think this is a reasonable target for some of these temporary systems. But I'll pass it off to Dr. Prislov, and I can review some of these concepts that really have been helpful in the perioperative phase.
Yeah, so just, one thing I think it's important to point out is even when I'm, if I'm talking about neuromodulation or not, I try to think about patients in 3 different categories. Oncology patients, trying to understand their pain better, whether their pain is due directly to their cancer, i.e. tumor effects, or maybe even delayed sequela like paraneoplastic syndrome. So notably, I have a patient who had upper extremity pain very much in the radial distribution after suffering paraneoplastic syndrome after prostate cancer. So that's one bucket. The second bucket is pain due to surgical intervention. Obviously, if someone has surgery to remove tumor or to have some sort of mass or revision, that pain is more of an acute state. And then lastly, pain that's due to cancer treatment itself, whether it be chemo or radiation. So, perhaps this patient falls into both pain due to tumor effects, but also pain following surgery and surgical intervention. And so, I think it's what you're showing, and this was a case series that was published in Neuromodulation in 2020, targeting these nerve roots with a temporary percutaneous system. I mean, the challenge always with some of these patients is, can you adequately identify pain that is localized to a specific or small enough area that you think you can cover? And so that's the challenge. And in some cases you can, and it's very much a large area. And in those cases, peripheral neuromodulation may not be adequate, and you may have to go with some other modality like spinal cord stimulation or intrathecal therapy. But there is a possibility to target nerves even in the lower extremity, like here showing at the L2 and L3 nerve root level. One of the other kind of areas or nerves that I've had success with just targeting lower extremity pain is the sciatic nerve, which is, obviously the largest mixed motor sensory peripheral nerve in the body, but you can cover a very large amount of territory, specifically below the knee and in the foot, with peripheral neuromodulation of the sciatic nerve, both with temporary or permanent systems. So next case.
So this is an interesting case where it kind of brings in light the concept of choosing the right therapy or for the right presentation. Peripheral nervous system stimulators and definitely, as you suggested, is a good option. What's your thought? And this is open to the entire panel. Would this patient be better served with a spinal cord dorsal column stimulation, or a intrathecal drug delivery system, or even some of the old archaic methods of neuroablation?
Hip ablation, yeah. Yeah, I mean, I can take a shot. I mean, I think, just my 20-second answer is it probably depends on the patient, what the desires of the patient are. Do they want a more invasive therapy? Are they committed to a peripheral device? I mean, I always say a peripheral PNS is not a set it and forget it sort of therapy. I mean, there is some, active, day-to-day involvement, investment in the therapy. So the short answer for me would be Might something like SCS be more efficacious? Possibly, but it also depends on the patient factors. And I don't know if Dr. Sin or Dr. Patil have thoughts on that as well.
I think that's a great point in terms of, the patient commitment, and do they want also, an indwelling device like an intrathecal pump that does require, significant maintenance, every few months or less, changing the medication, some of the logistical concerns about that. The location of being localized makes it attractive for something like peripheral or dorsal column stimulation. So I think kind of patient expectations or desires and some of the logistics around that, I think, are also important. Also, what is the patient's prognosis in terms of long-term, propensity to develop new or disease in other places, all goes into that decision making.
So I had a question, actually. So the traditional teaching was that it was very difficult to achieve pain control in mixed motor sensory nerves with peripheral stimulation because of the problem of crossover motor effects causing trouble. And so hearing that you do sciatic stimulation and other brachial plexus stimulation, I'm curious to know how often do you run into troubling motor side effects, and what do you do for them?
Maybe Amit's the best best one to answer that, since you've done the most probably nerve root PNS.
Look, I'll be honest with you. I think when you get really close to the nerve root, you're using very much lower intensities and you're staying at a higher frequency. The motor stimulation I usually see is usually because of an activation of a surrounding muscle that you're actually in, as opposed to actually going down the sciatic nerve and seeing your foot move in some way. I just don't see that very commonly with the 80 hertz, 100 hertz, and lower intensities. I do see, on the other hand, I think all of us can attest to, you'll put a peripheral lead somewhere close to a nerve and you'll turn it on, and maybe 1/5 of the frequencies will make it to the surrounding muscle and it'll start moving at that 1/5 rate, like 12 hertz, 14 hertz, 18 hertz, or something like that. But honestly, I had to think of any case I've actually had a peripheral stim that we use in our devices right now and actually had like motor stimulation very peripherally with the higher frequencies. I see that more commonly if you're close to a true muscle, but I'll defer to Dr. Prisloff and others have also. I just haven't seen it.
I would say it just depends how proximal you are. I would say, for example, if I'm stimulating tibial nerve at the popliteal fossa, right, none of those motor fibers have come off for the posterior compartment in the lower leg. So my experience has been, if I stimulate, say, tibial nerve or even sciatic nerve, I'm much more likely potentially to get motor involvement, as opposed to if I'm targeting just the foot and I'm getting the tibial nerve more distally, where a lot of those motor fibers have then peeled off and separated. So I think, Dr. Patil, you're right on. I mean, you absolutely can see it. And a lot of this, there's a lot of nuance here and a lot of creativity, frankly, where you can place these peripheral leads based on patient preference and where their pain is.
Maybe we'll progress to the last case, and maybe we'll do this last one real quickly because we're going to get to some of the other topics we have. Next slide. So Dr. Prisloff had mentioned, the third category of patients who may benefit from peripheral nerve stimulation is actual active cancer disease. So this is a case where we had a patient who could not tolerate opioids at all with nausea. A pancreas tumor was growing through the brachial plexus. The usual treatments were not stopping its growth. Eventually got radiated, which is fairly common. One of the things about radiated tumors is usually it's actually not vascular anymore. So even if they're on anticoagulation, it tends to be harder, at least from my feeling when I put needles in. But actually, we're nearly as worried about bleeding in those situations after they're irradiated. And one of the beauties of these devices is that it's a little bit easier to place than perhaps a neuroaxial system in patients who are their expected life maybe 3 months or less, and this person was in that category. So that's why she preferred not to have intrathecal pump. We had talked about all the different modalities we could do. I'll probably open up to the panel here, or we can move on to the next case. But this is a way we were able to stimulate the brachial plexus through the pancreas, which was one of our first cases also.
And I think the only thing I wanted to say, just with the limited time I have left so we can move on to the other panelists, is this case in particular really brings up the concept of coordination with both oncology and surgical teams to get a sense of what the treatment plan is going to be, and keeping in mind that there are significant limitations with MR capabilities with our current PNS systems. And so it's really teasing that out. You know, some of the systems are MR conditional with limitation. I know, you know, the current percutaneous temporary system is not MR compatible at all. And so you need to really plan accordingly, because you want to offer a therapy that's going to be in line with the treatment plan. The only other thing I would also say is just once again understanding wearables and, you know, the skin state of the patient surrounding the proposed entry site and where they're going to wear their wearables, because that could also be an issue in someone who has active cancer. If an area has been irradiated and the skin is you know, kind of broken down and essentially you know, dehisced, you have to be careful. So those would just be my comment for this case.
Thank you, Dr. Pritzlaff and colleagues. Perhaps we can move to the next slide. And I think given our time constraints, we might actually, next slide, please. We might skip this one, the next slide. We talked about the nerve root stimulation already. And so we went to Dr. Sind's case at this point.
Great. Next slide, please. So this is an actual patient I treated last year. So 58-year-old lady, she's got metastatic endometrial cancer, but she's responded well to kind of her current chemotherapy regimen. She's had stable disease over the last pretty much year. So she has left hip and left leg pain. This pelvic mass is compressing the lumbar plexus as it passes through the pelvis. She also, interestingly, a little bit uncommon for endometrial cancer, she had a periprosthetic hip fracture. So it was prophylactically pinned, then she had a hip fracture. So she's got kind of some mechanical hip pain as well as significant neuropathic pain in that leg. She had surgery, again, to treat this hip fracture that was then became a total hip. She's had radiation to the area. She's had some epidural steroid injections, which presumably, and not surprisingly, didn't help too much, because the problem is not necessarily the nerve root, it's the compression of the transiting lumbar plexus. She generally was pretty poorly tolerant of opioids. So she had nausea with some. She really couldn't tolerate the doses anywhere close to what she needed because of sedation. She also cared for her elderly mother who had dementia. She was on hydromorphone 2 milligrams a few times a day when I saw her. That was helped some. She really couldn't tolerate any of the neuropathic medications. She was anticoagulated. She had a PE a year ago, so she's lifelong anticoagulation since she has active cancer. But otherwise, she was medically pretty healthy. Healthy heart, healthy lungs. Her spine imaging was pretty unremarkable. No major either degenerative or compressive issues. Next slide. So the kind of thing we're going to talk about is, you know, what device for which person. So thinking about spinal cord stimulation or an intrathecal pump. This is not an easy decision, and rarely does one patient meet all the qualifications for one versus the other, but these are the things I try to think about. So maybe the most important thing, I think, is their disease status and what their prognosis is. So is this someone who has advanced, widely metastatic cancer, who has pain in multiple areas and prognosis is, you know, on the order of months? Is this someone living with a cancer like a low-grade myeloma, which is expected, yes, to likely progress over time, but they're stable for now? Is this a patient who's just in surveillance? They've completed their cancer treatments and they may have pain related to those treatments, but, you know, other than surveillance, you know, we have a good expectation that their life expectancy is more like years. So in addition to just prognosis, I think, what is the, you know, presumed course in terms of development of pain in other, especially distant areas? Is it generally expected, for example, pancreatic cancer? Generally, you know, we assume that when they have progression, it will be kind of in the abdominal area, as opposed to something like renal cell or lung cancer or breast cancer, where they may metastasize widely throughout the body and have pain in a lot of different areas. And just understanding each cancer, and the oncologists, I think, are good at this, even if none of us are fantastic about really knowing prognosis. It's also more and more over time, as genetics change, cancer treatments change, these paradigms change. Along with that, thinking about the location of the pain and how it may be better targeted by one therapy versus the other. Is it more neuropathic, more somatic, visceral, et cetera? Thinking about opioids and neuropathics, you don't want to leave something on the table in terms of appropriate dose escalation or trying those medications, which may allow the patient to avoid a more invasive procedure. Medical comorbidities, in particular, as it relates to the risk of anesthesia. So we sometimes see this, especially in head and neck cancer patients, we miss their window in terms of when it's really felt to be safe to, manipulate their airway in the setting of general anesthesia. As we know, spinal cord stimulators can be placed under local and sedation. It's not always ideal. It's going to depend on the patient, but that may be a consideration, as well as just kind of general heart health and lung health for anesthesia. And then technical considerations. So where are you going to be able to fit a pump reservoir or a spinal cord stimulator battery may preclude either of these or push you one way versus the other. You can do next slide, please. So this is just a kind of thinking about the general indications. So outside of this particular patient, but in general, why do we think of intrathecal drug delivery in cancer pain? Why do we think of spinal cord stimulation? There are three kind of main things we think about for intrathecal drug delivery. In general, we think of advanced cancer, but I typically think of three reasons. One, and I think the patients that do the best kind of very quickly are those who have cancer. They have pain that's attributable to that cancer, but they have dose-limiting opioid-related side effects. That can be constipation, sedation, nausea, etc. So I think those are pretty much a slam dunk. Other population is those that have, again, cancer-related pain, but they continue to have significant pain despite opioid dose escalation. So if they're tolerating those opioids and they're responding, as they progress to dose escalations, it's very reasonable to continue that. But it's if you start to get, out of control pain despite continuing to escalate, they're in the hospital with a severe pain crisis, et cetera. And then the third indication, which we're seeing a little bit more, it's still certainly a small minority, but especially as the cohort of generation affected most by the opioid epidemic starts to get older and starts to develop cancer, we have this population of people who have had difficulty with opioids in the past, either straight out addiction, requiring treatment, just some of the chemical coping that we can see with opioids, sometimes cognitive dysfunction precluding safe management of opioids, and kind of active substance abuse at times. So that can be something we may see a little bit more of in the future. We think about spinal cord stimulation, we think about, life expectancy that's maybe not normal, but it's not in the next few months. We don't expect that they're kind of quickly going to progress and kind of fail. In general, we think of a more neuropathic quality. There's more and more evidence coming out with, visceral pain being treated by spinal cord stimulation, but I think the traditional paradigm is more neuropathic type pain, a little bit more localized since it requires specific lead placement. May or may not be opioid sparing. And I think that's important. We all know that's the difficult part, certainly with chronic pain patients, is taking that next step of reducing opioid use. And the same may be true for cancer pain, especially if they have pain in different areas. All right, next slide. So this is just a little table that I kind of think of in trying to decide which is which. And what's hard is it's usually a mixed picture, right? It's not, this person doesn't have everything listed in the IT pump column or everything listed in the stimulator column. But again, thinking about prognosis, thinking about what their cancer status is currently, their location, we think about more localized pain, or especially in a limb, as potentially more amenable to spinal cord stimulation. And that, in my experience, is a more difficult pain sometimes to treat with intrathecal drug delivery. So neuropathic pain in a limb, for example, like that patient with the Pancoast brachial plexus tumor. Sometimes I'm very surprised, and those patients do fantastic with intrathecal pumps, but those are sometimes a more challenging situation. Then the character of the pain, what their spine looks like. So they have significant, spine disease, especially with, compressing the spinal cord or potential for compression. That may preclude in particular spinal cord stimulation in terms of placing the leads, less likely to be a problem with threading a catheter for intrathecal drug delivery. Timeline, so intrathecal pumps can be placed quickly. So we do not trial patients, cancer patients, for intrathecal pumps unless we cannot get the insurance to agree with that. But certainly for spinal cord stimulation, there does not exist that ability to skip the psychological evaluation and the trial period for placement of those devices, and that can take quite a while sometimes, and sometimes time that patients don't really have. And anticoagulation you have to think about. There are some ways to mitigate this in terms of things like a staged trial for spinal cord stimulation, but in those patients who are high risk, interrupting their anticoagulation multiple times can be dangerous. thinking about what their responsiveness to opioids is. If their pain is not that opioid responsive, intrathecal drug delivery can be a little bit more challenging. And then we think about risk. I think both are low risk. There is slightly higher risks in general in the literature with spinal cord stimulation as opposed to intrathecal pump, although it's not a huge difference. I think that's my final slide. So I think when it comes down to it, the other thing I wanted to talk about was, it's been mentioned briefly here, is the MR conditional labeling. So both intrathecal pumps and spinal cord stimulators, all companies have MR conditional labeling under certain parameters. And this is my big soapbox, is you really have to know what those parameters are. So they're conditional, depends, they have limitations on where the leads can be placed, what other things can be placed. For example, lead extenders, none of them have any MR conditional labeling. So if you use them, it's no longer feasible. Some of them, if a single contact is out on a stimulator lead, the whole device is not MR conditional labeled, depending on where the IPG is placed, which sometimes you have to be creative with in cancer patients in particular, given cachexia. You have to understand how long they can be on the table. There's often 30 minutes on, 30 minutes off. If your cancer patient needs CT and L-spine imaging for surveillance every 3 months, that is a challenge. How easy it is to get the device ready for taking an MRI. Some of the devices are very easy and the radiologists are familiar, some are not. So the other thing is what's called the SAR limit, which is the systemic absorption rate, which is basically influences how good quality an MRI is. It is a very simple way of describing it, but there are some significant SAR limitations with a couple of the company's devices, such that our radiologists say they are not able to get high quality spine imaging with those devices. And that's important if your patient particularly needs attention to the spine. So when we're talking about intrathecal pumps, there are two different main devices. One is generally MR conditional labeling without much needed to do to the pump. The other kind of requires it to be empty, requires a certain volume, and has to be refilled afterwards. So the logistics of that also should play into your choice in a particular device. So I want to save time for the rest, but if there's any questions or thoughts, we can take them at the end or move on right now.
I had another quick question, and since I'm taking away from my own time, I'll ask it. So this is a patient who has a visceral tumor that's invaded the plexus, which is presumably causing neuropathic pain, and you are planning to treat with intrathecal therapy. What are the agents that you use, and how do you decide based on the pain which agent to use, given that you don't do a trial?
Sure, that's a great question. The great thing about intrathecal drug delivery is we can change the medication if what we have started off with isn't ideal. But in a patient like this who has kind of mixed pain, I would typically start actually with 3 drugs right off the bat. So I would start with an opioid, kind of based on their current OME. I would add bupivacaine as well to target kind of both types of pain, but we often will also use a low-dose ziconotide in patients who have pain that's not as opioid responsive as we would like it to be, and that's quite low dose. So starting out at ziconotide 0.2 to 0.3 micrograms per day, so quite a bit lower. Also with the expectation that these patients likely will require escalation over time, so as not to overshoot. But these are the patients that we typically start with, often a 3-drug cocktail. When we've studied our reports or our patients, the most common solution is a combination of opioid and bupivacaine that we use. Second most common is opioid only. Third most common, but almost becoming our second most common, is this cocktail of 3 drugs right off the bat.
And then how do you decide where to put the tip of the catheter?
So this is, I wouldn't say controversial, but there's spirited conversations about where this is, depending on, I think, sort of the lineage that you came from with intrathecal drug delivery. So, so generally we place the catheter tip similar to where you might place spinal cord stimulator leads for the worst area of pain. Now that's hard if they've got multiple areas of pain, right? They've got shoulder and hip. Sometimes we try to split the difference and hope that the CSF circulation will get us where we need to go. And more often than not, we're successful. But somebody who's got kind of hip and lower extremity pain, we place the catheter tip fairly low, probably T10. It's someone who's got upper extremity pain, we're going to be mid to low cervical catheter placement, and then you kind of extrapolate from there. But not everybody feels the same way about that, but that's certainly our paradigm.
Have you used intrathecal therapy for head and neck cancers? And what
we have. They do Yeah, they do really well, surprisingly. Now we place very high, like C1 catheter, and we are very conservative with dosing. That's typically fentanyl that we start with because it's more lipophilic, so less spread. We'll often use, once we have a sense of their opioid need, add low-dose bupivacaine as well, and they do very well. What's tricky in those patients is we often do miss that window between when their airway gets a little bit scary. So, but about 10% of our catheters are high cervical catheters for kind of head and neck cancer, and I'm surprised at how well they do. They're also the only patient population we don't stop systemic opioids at the time of implant. So that population we do because we're using fentanyl. The conversion from oral to intrathecal fentanyl is not kind of standard, and the higher just risks with the cervical catheter that high, we actually do kind of cross titrate patients off their opioids and up on intrathecal drug delivery, which is not something we do with all of our other locations where we place catheters. We stop systemic opioids at the time of implant.
Thank you, Dr. Patel and Dr. Sint. That was a riveting conversation. I kind of wanted to jump in too and get some questions in, but we know we have some other topics to cover. So I'm going to give a little case that we had early on, introducing concept of percutaneous chordotomy, and then hand off to Dr. Patel, and we can actually ask him questions now. So next slide, please. So early on in our career, we've had patients that either had an issue with intrathecal drug delivery, so either a tolerance to bupivacaine, that can happen, large tumor growth expanding multiple nerve roots. So I know we have talked about catheter replacement, and there's some discussion on how these medications spread in the CSF. But we have a patient here, a 40-year-old male, who had advancing chest wall disease. So it was actually early on in the, I want to say T3 to T6 region, and we actually placed an intrathecal pump for him. The patient couldn't tolerate oral or systemic opioids, and actually did fairly well with the intrathecal pump. Unfortunately, the tumor then started progressing in the lower chest wall, and for whatever reason, as we increased our medications, we're unable to get complete control of this pain, switching through medication and clonidine. We did not use the Contyte at that time, and so considering hospice and thinking about sedation. And we called one of our good buddies, Dr. Patel, and colleague, Dr. Rosenberg et al., and said, "Well, can we start doing chordotomies in our hospital system?" And so I wanted Dr. Patel kind of introduce that concept, and then some correlates around it, some of the really good neurosurgical techniques that are available for us for cancer patients. So next slide, please. I'll hand off to you, Dr. Patel.
Sure. So as a neurosurgeon who's interested in pain, my approach is essentially one of three. It's an algorithm where there are 3 steps. The first step is, or the first question is, can I take care of the source of the problem? So for example, in the case of a herniated disc, or in the case of trigeminal neuralgia caused by compression, I can surgically attack this, get rid of the source of the pain, and thereby treat the pain. When that isn't an option, then the next step is neuromodulation. So I'm not altering or making any permanent change in the nervous system, and I'm using one of the types of therapies that we've been talking about so far to try to treat the pain. If I think that neither of those 2 approaches is either appropriate, or because of the patient's prognosis isn't likely to be helpful for very long, then I start thinking about ablative approaches. And really, percutaneous chordotomy has become my favorite procedure. What is done in percutaneous chordotomy is essentially a needle is inserted into the C1-2 inner space. You can see in the top right-hand corner an image. And what that shows is myelographic dye, which is injected. You can see a little bit of C2 there. And just on the left-hand side of the image, which is the right-hand side of the patient, you can see a little radio opaque needle coming in. This is aimed towards the spinothalamic tract, which is in the anterolateral quadrant, or kind of the 9 to 10 o'clock position. And so for patients who have unilateral pain, which can be neuropathic or nociceptive, and whose pain is essentially below the C4 level, which is what you can get to from this C1-2 approach. For them, chordotomy is a very good option. Next slide. So in terms of the technique, basically we take advantage of the anatomy of the lateral spinothalamic tract. We stick the needle in C1-2. Of course, we go to the contralateral side of the pain because the spinothalamic tract, of course, crosses at the level of entry and then ascends a little bit in Lissauer's tract prior to crossing. Traditionally, one uses the dentate ligament. This was when fluoroscopy was used to identify where you were. Now with computed tomography, you can see the entire cord, so that's less of an issue. In terms of where we aim the needle, we go based again on the anatomy. The crossing of the fibers results in the leg being more posterolateral and the arm being more anteromedial. And so we try to kind of aim based on that. Next slide. And so this shows a number of slices at C1-2, starting on the left and going to the right-hand side of the screen as you go down, showing the anatomy and also clearly how where the ring is absent, one can access the spinal cord directly. Next slide. And so the question becomes, well, how do you introduce a needle into the spinal cord? We do this with a 19-gauge introducer. What this somewhat scary slide shows is how the dura can be punctured relatively easily, but the pia on the spinal cord is quite resistant. And so what you can see in the image on the right compared to the image on the left are two things. One is that the spinal cord is quite displaced. And what has happened in that image is that the spinal cord was displaced and then the pia was punctured and the spinal cord then returned to the middle. So the needle went quite deep. Fortunately, this does not cause, this causes angina to the surgeon, but not to the patient. And typically patients do very well. All you need to do is back it out a little bit. Next slide. And you can see that the radiofrequency needle that is advanced through the introducer is very small. Once again, in this on the left-hand side, you see, or even the middle, you see relatively optimal position. On the right-hand side, you can see that you can go too far. And the question becomes, how do you know when to do the ablation? It's very important not to ablate other regions of the spinal cord that maybe the needle has found. And so the way we do this is with a little bit of electrical stimulation. Typically, a small amount of electrical stimulation will produce a contralateral sense of warmth. For me, I try for that threshold to be about 0.1 or 0.2 volts, so very low. And that tells me that the needle is well localized. Next slide. And so for me, the testing is physiological testing. What we can also use is the impedance of the needle to help us identify when we're in the cord. The CSF itself has very low resistance. The PIA has intermediate resistance. And once the spinal cord itself is entered, the resistance goes up because the spinal cord, after all, is largely composed of fat, and that is an insulator. The right-hand column shows the parameters. It's about 70 to 80 degrees centigrade for 60 seconds. Some do test lesions at 60 degrees centigrade. Honestly, I never do test lesions. I just make sure that with my physiological testing, I'm exactly where I need to be. In terms of things that one can see. If you have stimulation, you may get stimulation of the roots. Roots stimulate quite easily, and sometimes you can see trapezius stimulation, that sort of thing. That shouldn't concern you. What should concern you is, for example, if you see motor activity in the ipsilateral leg, which tells you that you're in the corticospinal tract. Next slide. And so in conclusion, cordotomy is an extremely safe procedure. It's actually a quite easy technique. Patients, we used to keep them in the ICU overnight, then we put them on the floor overnight, and it almost is something that one could do as an outpatient. We actually always keep patients overnight and do post-operative MRIs, but that's more because of our desire to ensure that they're doing okay and there's no signs of hemorrhage and so on. And so that's about it.
Thank you, Dr.
Thank you, Dr.
Real quick,
This was
a real quick question for you before we move on to Dr. Kalia. Would you do this for head and neck cancer at a different location?
Yeah, so head and neck cancer, essentially one can do what's called a nucleus caudalis DRES, which is a cordotomy, but it's done up higher. And that also can be done with percutaneously, but one is entering right at the base of the skull, essentially.
And last question I have for you is any experience with cingulotomies with tumor for cancer-related pain?
Cingulotomy is an excellent procedure for cancer pain. The effects last about 6 months. We actually have not done one at the University of Michigan, but it is directed towards the affective component of pain rather than the sensory component of pain. So therefore, for patients who have generalized, poorly localized pain and so on, cingulotomy becomes a very good consideration, but is of course much more invasive.
Thank you. I'll hand it out to Dr. Kalia, and I apologize for interrupting a little bit earlier, but I want to get those points through.
No, thank you, Dr. Gulati. And this is a nice segue to kind of quickly jump into referral pattern building, the development of a practice, and also thinking about differences between interdisciplinary model of care and multidisciplinary model of care. So my question to the panelist is, keeping those differences in mind, do you think one specific model has a better role in developing a true cancer pain program, whether it's in an academic center or a community-based center or even in a private practice? I'll start with Dr. Singh.
I think that's a great question. And I think we, over time, have moved from more of a multidisciplinary model to an interdisciplinary model, and I think have had more success with that. I think the challenges is getting the relevant people involved, especially if we're talking about an interdisciplinary model as opposed to multidisciplinary. Not just each person taking their piece and trying to apply it to the patient, but rather taking it more, how can we all interact with each other, how can our specialties interact, and that I think involves not only oncology, in particular the oncology APCs, I would say, who are often more tasked with symptom management and patients who maybe have a longer course, radiation oncology, in particular spine surgery, palliative care. Unfortunately, I think there can sometimes be almost an antagonistic relationship between interventional pain management and palliative care in some places, and bringing them into the fold as well and appreciating their expertise, I think has been helpful. So as we've moved more and more towards interdisciplinary management, I really think it's ideal if you can get buy-in, but starting with multidisciplinary maybe when kind of getting to know different folks in different specialties, I think is a way to start, but I think interdisciplinary is generally superior.
Great, thank you. Dr. Prislav?
I agree with Dr. Sin. I mean, just another thing that I think even at our institution, and if you're lucky enough and fortunate enough to be near a comprehensive cancer center, obviously Utah is one of those, Sloan Kettering is one of those, but that can vary depending on where you are in the country. But even, at our institution, I think one of the hardest things with providing good cancer pain care is the sense of urgency. I sometimes think we're not always good at kind of being able to expedite. You know, and there's hurdles even with neuromodulation that we're talking about. I mean, one of our hurdles sometimes has been, you know, getting the patient in for, you know, psychological evaluation, making sure that's done, making sure that's optimized, and, you know, kind of some of the things that Dr. Sint was saying, coordinating with the oncology team. But I definitely think interdisciplinary is important, having a good team, but also finding ways to respond to that urgency, because I mean, these patients are often in agony, and you need to find ways to fast track processes that, you know, in non-cancer patients sometimes can take weeks to months, and do it in a much more compressed time frame. So that's been one of the challenges, and also one of the realities taking care of these patients.
True. That actually, you hit the point really nicely there about, you know, there's a very narrow window of opportunity with our cancer patients, and we have to be quick. With the interdisciplinary model of care, Dr. Patil, do you think there is a role of doing a cohabitated clinic with specialties like palliative care, neurosurgery, where we can see these patients together and do a truly interdisciplinary model of care?
Yeah, so that's a great question. Let me back up just for a second and say that, you know, I think that as pain physicians, we often blame oncologists, saying that oncologists aren't interested in pain, and they aren't referring because of a lack of interest or a lack of knowledge. And I have come to, we have a large cancer center here at University of Michigan, and I've come to realize that really it's not an issue of knowledge or importance, it's an issue of time. And so essentially all of the time that they have allocated to the patient is absorbed in the treatment of cancer and of acute medical issues related to cancer. So time is important. And to answer your question, although it would be ideal to have an integrated clinic, and I'm fortunate to run a clinic with one of our pain anesthesiologists, so we see all of our patients kind of together there, often that's not very productive because the volumes aren't high enough. And so you almost need to have co-localized clinics where you're seeing your regular patients, but when there is a cancer patient or another patient who will benefit from interdisciplinary care, you can call in your colleague to see them. That takes a lot of coordination between departments and so on, but where it's possible, I think that's ideal, but it's often difficult.
Great, thank you. I would also like to ask all the panelists about one pearl which you will give to our audience here, and how to actually build a successful cancer pain practice. We'll start with Dr. Sint.
Okay, one pearl I would say is essentially under the topic of be available. So cancer pain's messy. That's what makes it very satisfying and very interesting, but also very challenging. So be available for the difficult patients, the substance abusers, the cancer patient with chronic pain, because that's how you get, you know, some of those more classic cancer pain syndromes. And then be available for them, you know, at the end of the day, you know, as a same day appointment, you know, unscheduled, stop in. I think that shows your commitment, which is what I think oncologists want to see. They want to see this, that you have the same commitment to their patients as they do.
Dr. Pritzlaff?
She stole my idea. Being available is important. You know, another one, honestly, is relationship building with our oncology teams. I think sometimes we get frustrated and say, you know, why am I not getting more referrals for X? And what you find is the oncologists are busy, and a lot of times they may not know what's the newest, greatest, and best. Meaning, you know, for example, we were talking about peripheral neuromodulation. I mean, a lot of what we're doing now is really, you know, PNS is not a new idea, but some of the applications are new. And so finding ways to build those relationships, whether that is giving grand rounds or you know, just going over to have lunch, but really trying to build that bridge, because a lot of times people don't know what you have going on in your wheelhouse until you tell them and show people how excited you are about what you're doing.
Great, Dr. Patil.
So it's what we all learned early on: able, affable, and available. We've covered available and we've covered affable. And so I'll talk about able. So expanding the breadth of your practice to understand these techniques, learning a little bit about the techniques that others are able to offer, and probably most importantly, giving up the ego, which is that I need to be the one to provide this care to this patient. I know that in today's medical world, it's sometimes hard to refer patients outside of a system or even to different departments. But you know, in the end, learn who your colleagues are who can provide the care best, and then encourage them to get interested in cancer pain and then work with them. So for example, in our center, I don't do any of the peripheral nerve stimulation. I have a colleague who is a neurosurgeon who does peripheral nerve, and a pain anesthesiologist who I do run a clinic with, but who does ultrasound visualization, but does it with the other neurosurgeon, because the other neurosurgeon has a peripheral nerve interest. And so affable, available, and able are the key, I think.
Thank you. I think you nicely summarized all the 3 pearls. So this was really great. Thank you. Thank you, the panelists, for taking out time off your busy schedule and being a part of this webinar. We do have a few questions from the audience. I think in the interest of time, I'm going to take a few of them. The first one is, can we mix opioids and ziconotide? And is it FDA approved? Dr. Singh, you want to?
Not FDA approved, no admixtures are approved. But as you can see, and the PAT guidelines support this, the use of mixtures of opioid and ziconotide, opioid and local anesthetic, the 3 are well supported and listed as, you know, 2nd, 3rd, 4th line therapy. So can you? Absolutely. You have to have a compounding pharmacy who knows what they're doing, but absolutely. And there's evidence to support it and guidelines to support your choice of it.
Thank you. Another question is thoughts about TMS for pain control. Transcranial magnetic stimulation. Dr. Patil?
So you know, I would say that TMS for pain control is a very intriguing, potentially beneficial therapy that's still in a research phase. So TMS, TDCS, there's very, frankly, motor cortex stimulation. All of these things are very interesting, seem to work some of the time. It's hard to know who it's going to work in.
Thank you. With that, I think we will conclude this webinar today. We'll give 2 minutes back. And thank you, everyone, for joining today and being a part of this webinar. Thank you, faculty. Thank you, Dr. Gulati. And have a nice evening and good night.
Thank you for putting this together.
Thank you, everyone.
Thank you.
Thank you.